went away to Boston University to get my undergraduate degree, medical degree here at UH, and then completed my medical training at LA County USC, which is arguably one of the biggest and arguably the biggest hospital system, at least emergency department in the country. So I've been back here for about 4 years training. And then also been involved in education on a larger sense, writing kind of lay articles, mostly for Vice magazine. I found that one of my things that I like to do is, whatever a good physician does do, is explain complex medical topics into ways that everybody can understand. And I like to doing it on a larger scale and on a bigger platform. And so because of those, I was tapped by one of my buddies who's a producer to consult on the Netflix series, which you can watch now and was eerily dropped right about the same time as this started blossoming out of Wuhan, is Pandemic, How to Prevent an Outbreak. So I was a medical consultant on that. So both being this being a disaster that is kind of moving globally, is in the emergency medicine physician's wheelhouse, which I am one, and then two, I've kind of brushed up on both pandemics and upper respiratory diseases to be able to consult on a series like this. So the article that I had dropped on March 3rd with Vice, they asked my opinions kind of on late February. So I finished the article on late February, basically saying like, look, the world has to prepare for this, because the only way that China stopped this from spreading and exploding any faster out of China was that really they instituted all these draconian measures, you know, drones going through the streets, speakers on every corner saying, look, don't go outside. Only one person out of your family unit can leave just to get food every week. So to expect that it wasn't going to go globally was pretty futile. So if you want to read that article, it's a little bit old by now, but still has a lot of good points in it. You can just kind of Google my name and Vice coronavirus. Little preamble that this is just a medical disclaimer, just saying, look, none of this substitutes for any medical advice given by you or medical professionals, so don't take it as such. And before we even get started, I want to introduce a concept that I learned as a medical physician and officer on Hikianalia, Hokulea's sister canoe. I was fortunate and honored to be selected to be their crew physician on the last leg from San Diego back to here. That was in late November of 2018. And really what I learned there was he va'a he moku he va'a. And what that means is a canoe is an island is a canoe. And you can see here, this is one of the photos I took. I'm kind of dabbling in photography, but this was, I think, day 2 or day 3, and the northerly winds right off the California coast were battering us. It was cold. And everybody in this photo kind of has a role. You've got Uncle Gary bringing the food. You've got Caniela down here in the corner, making sure the burner is still hot. You've got our crew, 3 or 4 of us still needing to steer the canoe. And what this sort of means is that, you know, out of all 15, if one of us went down, that really kind of put the spread the responsibility of the rest of us equally. And knowing that, you can kind of take that concept and spread it to not only your family unit, but your community, and then our island, Oahu, but also then our state, and then our nation, and then globally. So that we're all in this, and we're the only way that we're going to get through this is to treat everybody with grace, humility, and love and aloha. So knowing that there's hope, because there's the human spirit, and we've achieved so much throughout our tenure on this earth. So I don't want to, a lot of what I'm about to say can sound alarmist and dire, but I don't want to hide anything, but to know that, you know, the human spirit is going to get us through this. Okay, so what we're going to cover is where the world stands now, some virology and biology of the SARS coronavirus 2, as it's officially named, the symptoms and risk factors, 2 important periods that I think you should know, the incubation and latent period, something called R0, some moments on testing and some words on testing, what we're using to treat this and what to avoid, when to obtain care, when to go to the ER, and how to optimize your immune system. And then definitely time for questions, which Where I am right now, I can't see the question and chat bar, so we'll just kind of save those to last. I've got plenty of time. I hope you guys do too as well. We're not going anywhere, right? So we can do this. So this was just taken at 1:53 p.m. This is, if you guys want, I think this is one of the better trackers out there. It's put out by Johns Hopkins University. And so we've got 500,000 cases worldwide proven. And a total of 23,000, almost 24,000 deaths. And the US just became the country with the most cases, not the most deaths, which makes sense because we closed our borders too late. We're not instituting, and we did not institute the draconian measures that China did. So it's spreading rapidly. And you can expect those death tolls to climb. Mostly our hotspots at the moment are New York, Washington, Louisiana is picking up, New Orleans at the moment. And one thing I want to post or put your guys' attention to is that kind of graph all the way down on the bottom right. It's that yellow dot. And you can see that the rates are just kind of skyrocketing now. And we've all seen some of the curves where this is pretty steep. What we want is a flat curve. We don't want a steep curve because the steep curve is going to overwhelm our medical systems quickly. And what's happened in Italy, what's happening now in New York. So we'll get to that a little bit later. Here's NPR's doing their own national cases here. And so New York by far has the most cases, and that mostly in the New York City metropolitan area. And just everybody's living in such higher densities compared to the rest of the country, and also using public transportation and much more frequency that's contributing to these high rates. Hawaii, I didn't check the news today regarding if there's been any more, but as of yesterday, we've got 95 cases. And here's a breakdown per state if you guys wanted to know. And what have we seen in the past? I mean, the only thing that is really comparable is the 1918 Spanish influenza. And here's a picture of a hospital bed or hospital ward that they had back then. And Spanish influenza, it's a different virus. It's an influenza virus as compared to a coronavirus, but it really came in 3 waves. And it came in a spring wave in early 1918, a fall wave of 1918, and then another spring wave in 1919. And in total, most estimates put about 50 to 100 million people died. And with only 1.7 billion people on the earth at that time, it's quite a lot, quite a huge percentage of people. It was about a 2.5% mortality rate. Most estimates are putting, numbers are skewed in the beginning of pandemics and epidemics. You've got Italy, which has like a 9 or 12% mortality rate, but then you've got South Korea that's got like 0.4%, and Germany as well. So most estimates are saying that this is going to end up right around 1%. So that's where we're looking. Back then, it happened right in the middle of World War I. And so with the troop movements going from Atlantic to European and cross Atlantic, and also vice versa, that facilitated the virus movement. But here in our modern society, with such vast movement of people, the wave, how it's going to come in waves, is more not akin to the virus itself, but how we're combating this with our social distancing and quarantining methods. But it's a little bit like comparing apples to oranges, because back then we didn't have proper antibiotics, we didn't have ventilators, and interestingly, the Spanish flu killed a high proportion of 20 to 40-year-olds, whereas we're not seeing that with this coronavirus. The reason being is that it was an H1N1 strain that most older people had already been exposed to when, probably in their mid to late 1800s. And so they had some cross immunity. But as we said, and anybody knows, when this was first categorized, it was a novel coronavirus. So nobody has immunity to this unless you've already been infected. So that's the differences, and that's what kind of is most comparable in our history, modern history at the moment. Little notes on virology. So what does this look like? And it's nib coronavirus because it's got these spikes, which base corona means crown. And on the microscope, it has these little spikes appearances. It almost looks like a wheel. So that's why it's called a coronavirus. But there's 4 types of benign human types of coronaviruses. 25 to 33% of them are result in the common cold. Excuse me, let me rephrase that. of the common colds, 25 to 33% are due to coronaviruses. So there's a good chance your last cold was due to a type of coronavirus. And they're named here. I'm not going to go through them. They've got like weird letters and numbered names. But there are the pathologic coronaviruses, and of modern history and of the ones that we know, SARS coronavirus in 2003, which I think everybody's mostly familiar with, that came out of Hong Kong or China, and then had a big outbreak in Hong Kong and Toronto. That had about a 10% mortality rate, but was much easier to control, and we'll get into the reasons why later. And then you've got Middle Eastern respiratory syndrome, MERS coronavirus, that blossomed out of the Middle East in 2012. And actually, there's still every month or two, there's still a couple cases, and they're mostly seen in camel workers. But they're mostly in Saudi Arabia, but they've caught on to where it's coming from, and most of the people that do have it are isolated very quickly, so it never really kind of gets out of control, although there is still a possibility. But the mortality rate in MERS is much, much higher, closer to 40%. So we're actually kind of fortunate that this doesn't have a much higher mortality rate. Still high, but not anything like SARS and MERS. Okay, so SARS coronavirus 2. So SARS coronavirus 1 caused the original SARS. SARS stands for sudden acute respiratory syndrome. And if you look at the animation or little cartoon here, you can see those spikes, the corona, and how it affects the body is that it attaches to these ACE2 receptors, mostly lining these special types of epithelial cells in your lungs. And so it attaches to that and then kind of gets enveloped and invaginates into the cell, and then injects its RNA into the cell and hijacks the cell's machinery. And basically this cell is not doing its normal cell things other than now it's being told to make a bunch of viruses. So that's how it replicates. There's this really kind of new research about this particular virus that shows that it activates this thing called furin. And furin is not activated by the original SARS. And what furin does is it cleaves this spike protein, and it helps and bring it into the virus. And this furin molecule is not just in the lungs, but it's also in the small intestines and in the liver. So in the sicker patients, that's why we're able to get a little bit of virus coming out of the stool of these patients. And also we're seeing a little bit of liver failure. Bad news is it makes it more pathologic, meaning it's spreading it quite quicker and more infectious. But the good news is that it's a potential side for treatment. So there is some research going down on, hey, look, if you can inhibit this furin molecule or find a drug that does that, that might be able to curb this virus. So pluses and minuses to it. And so how did this get to us? There's a concept called zoonosis. Basically, it's a transfer of infectious diseases between species. And influenza is a perfect example of this, because everyone knows, I think, heard of like swine flu and bird flu. And so influenza has a reservoir in both birds and pigs. And what happens is that influenza is notoriously terrible at replicating itself. And so it can cause a high rate of mutation, high enough that, especially in pigs' immune systems are very, very close to our own. And it can mutate enough that it can jump from pigs and then onto humans. And then it can even go from pigs to birds, back to pigs, and then gain the necessary things that cause really, really high infectivity and pathogenicity, and then jump to humans. Bats are another example of a large group of where zoonotic diseases come from. And you can see a picture there where they're all huddled really close together, and they live in like these millions and millions huge colonies where they're all, if one coughs on another one, like the virus just kind of spreads. And the virus is just like any other biological entity on this earth, just like us. Like, we were only really put on this earth to make more of ourselves. So the virus wants to make more of itself, and it wants to do it as efficiently as possible. Bats have been proven to be other reservoirs for the Marburg virus, which is not as frequent as Ebola, but it's a very close cousin, does pretty much the same thing. They're hypothesized, but never exactly proven to be the reservoir for Ebola. SARS, the one that the original SARS coronavirus that happened in 2003, has been proven to be from bats. Then it jumped to a civet cat, which I have a picture there right below the bat. It's like this weird little mousy cat thing. And then go to humans. And then the Middle Eastern respiratory syndrome virus went from bats to a dromedary camel and to humans, and still does so, as I said, every month or two. Right now, the virus that causes COVID-19 shares about 96% of its genetic material with a bat coronavirus. So we're pretty sure that it comes from bats. Whether there was an intermediary host like the civet cat or the dromedary camel, we're unsure. There's been hypotheses that it's a pangolin, which is like this weird aardvark type of animal, but it's looking unlikely that it's going to be the pangolin. But it's just so early in this disease, and I think there's been 800 papers released in the last 3 weeks trying to study this. We just don't know yet. All right, another concept that I think is good to know is something called R0, and it's the basic reproduction number. And if we look at this little 4-quadrant thing, I'll read the top left. It's the average number of people that one person with a virus infects so basically, if we jump to the right, if one person is infected, you see that red person, on average, 2.5 people, and most estimates some are even as high as 3, are saying that 2.5 people are infected from it. And to put that in perspective, H1N1 swine flu back in 2009, which was a pretty notorious disease, only has a R0 of about 1. Most people say 1.3, but a range of 1.2 to 1.6. And then Ebola is even less than 2 as well. Ebola is notoriously not like a super transmissible disease, but if you don't take the proper precautions, yes, and you're taking care of somebody without the necessary protective equipment, you will get it. The highest R0s in the medical literature are probably measles. Measles has an R0 of 12, so that's pretty high. And that if one person has measles and there's 12 people who are susceptible to it or haven't got vaccinated, 12 people are going to get it. And you can see how this can branch out pretty quickly. In that, like if one person has coronavirus, gives it to 2.5 other people on average, that tree is going to blossom fairly quickly. It doesn't sound like a lot, but if flu goes globally every year and it only has an R0 of around 1.3. So you can see it's about twice as communicable as influenza. What goes into making the R0 number? If an R0 is greater than 1, the pandemic will continue. Basically, if you're infecting more than one person, it's going to continue. What we want to do is we want to drive that R0 less than 1, so that if Kino gets this, he doesn't give it to an average of 2 people or less, right? So we want to keep this down. There's 4 factors that go into this. And you can remember it by dots. There's duration, opportunity, transmissibility, and susceptibility. I'm sorry if this is getting really detailed, but I think it's a point that we need to know. So duration, how long are people sick from this disease? If you're sick for longer, you're going to have more opportunity to transmit this. And then one that I think is really important is opportunity. So how many people do you come in contact with a day is going to factor in how many people you're going to spread it to. So that's why our social distancing and staying home is vitally important. That's right now, our only way to combat this disease. And then transmissibility is a probability that if I was to talk to somebody that had this disease, if I was within 3 feet, or me in the hospital system, if I was treating them, how likely is it going to get across? And this virus is proven to be probably because of the furin, and also because of that when we cough, it kind of these droplets get aerosolized for a while, and we'll get into this airborne or not a little bit later. It can get across to me. So I've never come in contact with a disease where I have to wear eye protection around my patients. So this is totally new. Then the last one is susceptibility. So we're all susceptible. This is a brand new virus. We have no immunity to it. No one's seen it before. And that's where vaccines and antibodies come in place. So it's important to note that vaccines are not in the near future, but I would say in the moderate to future. So we'll get to those a little bit later. What are the symptoms? It's an influenza-like illness. In the medical speak, we like to just abbreviate it with ILI. The good news is that 81% of cases are mild, so that's really good. That's a really high percentage. And the most common symptoms are fever, dry cough, and fatigue. So mostly a dry cough. If you're having sputum production or congestion, it's probably more later in the disease. And then followed by shortness of breath, and those are more severe symptoms. You can get some sore throat and headache. Interestingly, you don't get, patients with this don't get so much of the chills. And I know, I mean, we've probably all here had influenza, and the shaking chills is an uncommon feature of this coronavirus. And then if you're congested, if you have like all sinus congestion, not saying it's not coronavirus, but it's unlikely to be coronavirus because it's only got about a 5% chance of having that. And then I also highlighted diarrhea there. So the run on toilet paper is a little bit strange, but I get it that people just don't want to run out of that stuff. But there's a pretty low rate of diarrhea. And then the last one I highlighted is anosmia, or a lack of smell. Any upper respiratory virus, even flu, can cause a temporary lack of smell. So this is not something that's uncommon. We don't know the percentages right now. That's only something that's kind of been reported lately. As you can imagine, the other features of the disease are probably more important and more pressing. My guess is that this anosmia is not going to be permanent, and not something that'll take out your smell forever. But you may, I don't even know the numbers yet, but you may exhibit some, if you were to catch this, some lack of taste and smell. Two other periods to keep in mind are latent period and incubation period. So the latent period is the time from when you contract this virus to the time of becoming infectious, okay? Very different from the incubation period, which is the time of contracting the virus to the time where you start having symptoms. So if you can see in the top gray there, this is just a little schematic of it. The latent period can be anywhere up to 1 to 2 days is what we're thinking. And then the average incubation period is around 5 to 6 days. So there's a period of 4 to 3, most people say 3 days, where you will not have symptoms, but you can be infectious to others, which is what's caused this virus to spread so rapidly and so globally. With SARS, the original SARS, you were only infectious when you had symptoms. So it was really much, much easier to control this virus because, hey, if you have symptoms, lock them away, put them in the hospital, take care of them, isolate them. And the R naught actually, once we started instituting those measures, went less than 0 and the infection died, or the pandemic died. So this has proven to be much, much trickier because you can be walking around without symptoms and still be spreading this. So that's why it's very, very important for everybody, doesn't matter how old you are, to act like you have this disease and stay away from as many people as possible. So we'll get into that a little bit more later. What are the risks and comorbidities that factor into the mortality rate here? And the graph on the right, you can see as you get older, your risks of dying from this disease, to be just quite frank, are a lot higher. And we see the same thing with influenza, not nearly to this extent, but basically the older you are, the more you're at risk of perishing from any disease, even the benign coronaviruses that I mentioned earlier in the lecture. The predominant comorbidities that will cause you to perish as well are those listed: cardiovascular disease, diabetes, hypertension, respiratory disease, and cancer. And if you've got a combination of those, that even puts you at a higher risk. In general, you can just think of this as, most people are like, oh, you know, it's just kind of a flu, nobody, you know, we shouldn't worry. In general, you can think of this as just being 10 times more deadly than seasonal influenza. The overall mortality rate we think is going to end up around 1%, and the mortality rate of seasonal influenza is about 0.1%. So about 10 times more deadly than seasonal influenza, and double as contagious. So those two combinations are making it a beast for our medical systems. And what happens when you get this disease? Here's a timeline of onset of symptoms to if you were to become very, very ill, where what days it normally happens. So it's usually around day 7 to day 8 where you start feeling the shortness of breath, the sickness, and needing hospital care. If you just have the mild form of disease, like, kind of like Tom Hanks has been having, just a little bit of rundown and feeling like the flu, a little fever and fatigue, some cough here and there, it usually only lasts 10 days or so. If you need to get hospitalized, it's about 2 to 3 weeks that you'll be experiencing disease. And if you're critically ill, like you need to get into the intensive care unit or you need to get on a ventilator, it's going to be closer to 6 to 8 weeks, which is quite a long time to be in the hospital, and why we need to keep that curve nice and flat. And what happens when you do get really ill is something called, as I mentioned, acute respiratory distress syndrome. You can think of your lungs as big. On the left here, the healthy alveoli, and alveoli is basically looks like a big sack of grapes. Well, it's a very small sack of grapes, but it's a sack of grapes in your lungs. And what it does is it increases the surface area of your lungs so you can exchange oxygen and exchange carbon dioxide and do all those things that help you breathe and get oxygen to the rest of your body. And surface area wise, what this does is you've got about a football field of surface area of these alveoli in your lungs, which is incredible and a huge feat of evolution, and what helps us run those marathons in 4 minutes and all, or miles in 4 minutes and all that. What happens in acute respiratory distress syndrome is over on the right, where basically these alveoli, the virus gets in there, infects the cells, and your immune system produces such a strong response that it starts trying to kill the virus, but in the process, it's also killing healthy cells, killing infected cells. And you just get all this kind of gunk of cells build up and fluid and inflammation. And what it looks like on chest x-ray, I think most people have seen a normal chest x-ray, is those lung spaces should be black. You've got the heart kind of in the middle to the left, but those lung spaces should be black, which means, good air transport. Because basically, your lungs should be mostly air with a minimal amount of tissue, but this white space that's now invaded both your lungs is fluid. Really, it's fluid. So your lungs are filling up with fluid in ARDS. We abbreviate it ARDS or ARDS. And so it's important to flatten the curve, and we've all heard, and I think most people have seen this, that in the red there, without protective measures, that curve, if everybody gets sick at once, is going to quickly overwhelm our healthcare system. And if we do our social isolation and our social distancing measures, we can flatten that. And it's not going to change the amount of cases, because 50 to 70, just to be quite frank, 50 to 70% of us are going to get this virus before we're able to treat it properly or have a vaccination. So, but what we want to do is spread those cases out in the longest time possible, because as I mentioned, 81% of cases are mild. That's a great thing, but 14 cases are severe, so they need to be hospitalized. And then 5% roughly are critical and need ventilators. Doing a quick math calculation is that if you've got 1.4 million people that live in Hawaii, let's just say half of them get infected in the next 2 to 3 weeks, right? So that's 700,000. If, let's just say 10% end up being severe, that's 70,000 people, right? That need to be hospitalized. If 5% are critical, that's 35,000 people. We've only got 3,600 hospital beds in Hawaii, and 65% of those are already taken up with our normal non-COVID related diseases, heart attacks, strokes, other infections, small bowel obstructions. So we're already 60% full. And we've only got 560 ventilators on the island at the moment. So flattening this curve is very, very vitally important for our island and our healthcare system. Because if we get overloaded like Italy did, Italy had a very, the north of Italy, Lombardy is like their crown jewel of their medical system. And they had an 8-minute ambulance response rate, which is terrific. So you call the ambulance, 8 minutes, it's there. It went up to, and is still as high as 1 hour. And so if you're having a heart attack and the ambulance doesn't get to you in 1 hour, you've missed that golden hour of getting perfusion and ventilation to your heart muscle that you need, can only be done in the hospital. So keeping our medical system afloat is why countries, I know some people are like, why are we overreacting? But really, it's going to burden us in ways that we can't even help the normal non-COVID emergencies if we don't enact. So how is this spread? It's droplet spread. I know this says Ebola and measles and coronavirus isn't listed on it, but it's a droplet spread. It's not airborne. There was a study and that said for about 3 hours after the virus was nebulized. And what nebulized means is that it was put through this fine mist. If anybody has asthma or knows anybody who's ever had asthma, a nebulizer machine is something that creates this fine mist that you can inhale the drug more properly. And so it's not from a cough, it's from specifically this tool that is used to purposely aerosolize little tiny droplets. So it does it really efficiently. So after they did that, they were able to detect the virus for 3 hours. So that does not mean that it's airborne. And so I know people have been kind of freaking out about that. So it's droplet. Basically how this spreads is somebody's coughing or somebody's yawning or somebody's sneezing, and the droplets kind of leave them, and at most will go, here it says Ebola 3 feet, but I would say 6 feet at most is where the droplets are spread. But the danger is somebody coughs or somebody touches something on their hand and then touches something else or rubs your eye or rubs your nose. So that's how you're going to get this. And it does last fairly long on steel and polyurethane, up to 3 days, which is a little bit scary, I would think. Good news that I didn't put in the lecture here is that UV light actually kills this virus. So seeing anything outside that's out in the sun is probably a little bit safer than being indoors, i.e. going to somebody's house party or going to a play date or something like that. But still, you don't know if somebody was just there at the bank machine or just there at that railing and touched it. And so I would just be careful about, religiously washing your hands. We'll get into that more later. And so what happens when you touch something is you create a fomite. And basically a fomite is an object that can transfer infection. And it can be anything from a coffee cup to a utensil, to a railing, to a doorknob, to a light bulb switch, any of those. So a word on testing, and we've never seen anything like this, but every municipality in the world, doesn't matter what country you're in, is clamoring for the same supply. And so to get these tests, you have to have, what happens is you have a specific nylon swab. It's not a cotton swab, and it goes way up into the back of your nose. And you've got to leave it in there, and it goes into the other nostril. And so those swabs themselves are in short supply. And then the pipettes that the lab techs use to put the reagent, which is a chemical that is used to keep the virus alive, are in just short supply. And these swabs are largely manufactured in China and Italy, which are both under lockdown at the moment. So our supply chains are really, really, really low globally. And to be quite frank, many states on the mainland are just unable to test. They just have no capabilities at this moment. And where I trained at LA County and in New York, they're only testing those sick enough to be admitted to the hospital. They've kind of put their hands up and being like, look, we've got so little supply that we're only going to be testing those that are sick enough that are coming into the hospital, because we need to know, do our providers need to be extra careful and use an already short amount of protective equipment that they have. Thankfully, we still can test in Hawaii, so that's good news. And there's still pretty stringent criteria. And I'm not going to get into like, should we have had more testing before? The answer is yes. And I'm not going to get into any sort of political and point any fingers or anything of that nature. We just kind of, just like I learned on the canoe, you gotta make do with what you have. Testing, a little bit more on testing. Does everybody need a test? And right now in Hawaii, only those displaying symptoms, so having cough, dry cough, fever, anything that feels like the flu, and one of the following. Either you have any of those major comorbidities or pre-existing diseases, or you're over the age of 65. Or you're in a high-risk occupation. You're a healthcare worker, where if you are infected, you can spread it to a lot of people who are vulnerable. If you're a hospitality worker, you've been around a lot of tourists. If you're in the TSA, if you're a flight attendant, cruise ship, or a bus, they put bus driver down there. And that is from the Queen's COVID line. And all of this is changing very rapidly. So what I'm saying now could already be debunked by this afternoon, or could be debunked by tomorrow. So don't take this as gospel. If you're having mild symptoms, if you're just having something that feels like the flu, we're still in the tail end of flu season. So if you haven't gotten your flu shot, it's probably a good idea because it'll help you from being confused in that, hey, do I have flu or do I have coronavirus? But I would utilize your primary care physician and the drive-through centers that you can call in advance. And if you're going anywhere, please, please, please call in advance, especially if you're trying to go to the emergency department. But all of this is a very, very fluid situation. When should you go to the ER? In general, every case is specific to you, and so I can't give you any specific advice. But if you're ever having chest pain, shortness of breath, or air hunger, or you're unable to rouse your family member, or they're just persistently lethargic and just looking very, very unwell. If you're having mild symptoms, like, hey, look, I have a fever, I have a cough, this is no reason. Most people in Hawaii won't test you. We need to save those for the people who are really sick. As I mentioned, this is a global shortage. Maybe that will change in the next coming months, but right now, this is where we are. If you're just having mild symptoms, your best bet is to just, act like you have it, act like what you would with the flu, and isolate yourself, get a mask if needed, or we'll talk about masks in a second. And really just kind of do the same things you would for the flu. What to avoid? There's been a lot of talk about ibuprofen and other non-steroidal anti-inflammatories, and this is not proven. It's a theoretical and a hypothetical effect of this drug is that it can increase those ACE2 receptors that the virus latches onto. And so if you have an option, I would use Tylenol. This could change. There could be some studies that come out that definitely debunk this or that definitely prove it. But I would say right now, because of the hypothetical increase in ACE2 receptors, I would avoid ibuprofen if you can. Always talk to your doctor if you have any questions. How to protect yourself? I think we've touched on it already, but self-isolate, wash your hands almost to the point of being neurotic about it. And when you do feel like you need to get care, seek it remotely. Because the last thing you want to do is think that you have this, but you have maybe another benign type of coronavirus, or you have the flu. Show up at an ER where I've just seen 3 or 4 likely cases. You just sat down where that patient sat down, and now you're touching everything that they just touched. And if you didn't have it before, you have it now. So it's like running into a burning building. So only try and seek it remotely, and only use the ER if you really feel like you need it. Social distancing is key, being 6 feet away, and what people consider in the Department of Health considers close contact is being within 6 foot of a person for 10 minutes. To touch on masks, right now we're so short that I have to reuse the masks that I used a week ago. So I have like a bunch of masks that I've put in the closet that I'm hoping in a week, if there was virus on it, are going to die. And then I'm going to reuse the mask that I previously used when it should only be a one-use mask. And so for us in the medical system, it's obviously not ideal. And most hospital systems here on the islands only have about 2 weeks left of supply, even rationing it, as I mentioned. So masks to be used, I would say only use them if you're sick. If you've obviously have cough, fever, it's going to help you from expelling those droplets and creating fomites in the environment all around you. But in general, if you're not sick, a mask is going to cause you to touch your face more. You're going to remove the mask in the wrong way. And if you just touched a fomite, you're going to now touch your eye, and it's just going to cause more problems for you. So in general, only use masks if you're sick. Now let's jump a little bit into how to kind of optimize your immune system to fight this. And exercise in general is always, always good. And one, just for your immune system, but two, we got to take care of our mental health as well. And exercise creates all those endorphins that helps us feel better. But I'd urge you to look at that pink little arm in this little schematic here, in that exercise does create anti-inflammatory effects. And if you go like high intensity exercise, if you go really, really strenuously, your body has to release and your muscles release these anti-inflammatory cytokines, these basically chemical messengers that tell your muscle like, hey, don't explode. We got you, don't worry. As soon as we stop working, you're gonna have time to rest. But as soon as that muscle stops working and is resting, those anti-inflammatory cytokines now kind of permeate throughout your whole body. And there's just something called an immune window after really intense exercise, where your immune system is actually like in a little bit of a quiescent silent state for about 24 hours. So in summary, I would do something that's around 60 to 80% of your max heart rate. And you can easily get your heart rate, max heart rate, by doing 220 minus whatever your age is. So if I'm 35, 220 minus 35 is 185. Yes, 185. So I've been concentrating on just doing kind of, you can go like a little bit longer if you want, but don't do the really high intensity things, and definitely not high intensity weightlifting either. So that's a thing on exercise. Diet and supplements. So a lot of people have been asking about vitamin C. High dose IV vitamin C has been proven. They've tried to give through the vein 3 grams over the span, 3 grams per day over the span of 3 or 4 days, and it's been shown not to be helpful in this. I would recommend just taking a daily multivitamin. Most of the vitamin C's and the supplements that you take anyway are not absorbed by your body, and it just creates, for lack of a better word, really expensive shishi. So I wouldn't go and invest, and you can also overdose on vitamins too if you take too much. So just take whatever your normal regimen is. There's no need to increase or decrease. In general, if you have a well-balanced diet with fruits and vegetables, you're going to be absorbing much greater amounts of vitamins than taking supplements. So I would just continue to do that. Meditation is something that I've really focused on trying in the last couple of weeks. And this is a study that was done on specifically a transcendental meditation technique. And it doesn't matter what type of technique it is. It's basically transcendental meditation was commercialized, and they have money to put towards making a study. But it decreases the stress hormone cortisol. And we know that when cortisol levels go up, our immune system is hampered. So anything you can do to decrease your amount of stress, especially since we're all locked in, talking to each other over this instead of in face to face, not seeing our family and friends, everything is a little bit more stressful. So I would try and work into your schedule some meditation classes, and there's lots of free ones online. There's Calm and Headspace apps. I like Headspace, and it's ideal to do the exercise and meditation before you turn on the world and everyone, you're like, oh God, like another 100 deaths, or now we're up to 120 cases in Hawaii or whatever it might be. So ideal to prime your body and your mental state before you open, as I say, turn the world on at this point. No little word on social media is that all these social media companies hired psychologists, just like they did in Las Vegas in the slots, in how to keep us coming back. So these things are trained and made to keep us coming back and basically get us addicted. So I'd be careful about spending too much time on social media, because there isn't much to do anymore, and so this has become filling a lot of people's time. But I would try and do once a day or twice a day for at least no more than 30 minutes. And same goes for news. Like you just be glued. For the first week or so when this virus really happened, I was glued to the news, and I just found, like, I don't know if it was clenching my jaw more or what was happening, but I just found myself getting more anxious and more anxious. So like, it's important to know what's going on, but you don't need to know what's going on every minute of every day. So ration it. Some comments on treatment, and this might be where many of the most questions are coming from. And so I'm going to get into detail about chloroquine and hydroxychloroquine, which was touted by our president, I think, prematurely. And here's the reasons, and bear with me if this gets a little complicated. But it's a 70-year-old malaria drug, so it's quite an old drug, so it's cheap to make, and there was a lot of it until this surge went on. But the study that was done in France is observational only and very, very poor evidence. So basically, there's only 26 people in the treatment arm. You've got a treatment arm where they got the drug and a non-treatment arm. There's 26 people, but only 20 people completed the trial, the treatment arm, because 3 got so sick they went to the ICU. 1 couldn't tolerate the medication, and then 1 died. So that's pretty significant. What they actually studied, and they said that, it seems like it works, was that they only studied viral loads in the nose. So, all right, so maybe there's this weak evidence in only a really small amount of people, and 26 people was like I don't know how you can make so many conclusions off of such a small study. But all they really showed to show efficacy was that they swabbed them before the medication, they swabbed them after, and there was decreased amounts of virus in the swabs. Clinically, they didn't really track them too well, and as you can see, like one died and 3 went to the ICU. What they're basing a lot of this on is that in vitro or in a test tube, it seemed to work. But that also seemed to work for chikungunya, which is it's a viral disease that's very similar to dengue. So the test tube of when they tested it in chikungunya, it seemed to work. But then when they started giving it to people with chikungunya, it actually made people worse. So you can't draw too many conclusions from it. And then it's also it's very toxic and a part of the one pill can kill club. And what that means is if any of you have kids at home, if they get their hands on this and somehow eat it, and they think it's candy or a lemon drop or something, it's so toxic to young persons that it can actually cause a fatal arrhythmia and kill them. So it's part of that one pill can kill club. And now it's basically you can't get it here on the islands because people have sort of hoarded it. I don't know any pharmacy that carries it anymore, and we only have 80 doses at the hospital I work at. But this is a very important medicine for a lot of different people who have already autoimmune diseases, like people with lupus. They need to take it on a daily basis, and if everybody's hoarding it, they can't take it. Would I tell my family members to take this? Absolutely not. Only if they're so sick that they need to get into like the ICU. It's the only thing that maybe might work. It's almost like a Hail Mary at this point. And so I would suggest against having it. The next one is Kaletra. It's a HIV combination medication. Unfortunately, there was a pretty well-designed study that came out of China where not 26 people, but something a little bit more rigorous. I'd like to see more, but 250 or so people took it and it showed of no benefits. So unfortunately, Kaletra is out for most people. The most promising one is remdesivir, which is an Ebola medication. It seems to be somewhat working. We don't have all of the results yet because the studies they're actively studying, is it a 5-day or 10-day course that's going to be the most beneficial. Those should be out in early to mid-April. And so obviously we would definitely hope a 5-day course would be much more beneficial because that would mean more drug to go around, but we'll see what happens. So that's the most promising one to date. And there's another one called Acterma that's being studied as well. It's a anti-interleukin 6. Interleukin 6 is one of those inflammatory cytokines that I sort of touched on earlier. Basically, it's counteracting the interleukin 6, and it's currently being studied at the moment. One that's also very promising as well is there's a monoclonal antibody, and what that means is you have a billion different antibodies in your body right now that have been exposed to billions of different types of bacteria and viruses. And what a monoclonal antibody is basically an antibody, one type of antibody. It just attacks one thing. I'm sorry, it's raining pretty hard in my house. I hope it doesn't get too loud, but I'll keep going. So it's a company out of just San Francisco. It's called Distributed Bio, and we actually followed them in that pandemic show. And they're genetically engineering an antibody that was used from SARS and making the part that attaches to the virus specific to this new SARS coronavirus 2 virus. And what it is it's an IV infusion, and those antibodies will circulate throughout your body and won't break down for roughly about 8 weeks. And it'll definitely be very, very helpful for medical workers and people on the front line, but also those who are really, really so ill that, and I'm not gonna lie, monoclonal antibody is gonna be expensive. And so we're gonna need, and it's gonna be hard to produce in mass quantities, but it's very, very hopeful that they can get that done within the next couple months or so. And then there's a vaccination, and several have already been developed and have skipped the animal phase, which is kind of unheard of. Humans are already being injected with something that's never been injected to anybody before, and so bless those brave souls for doing this. And at earliest, it's going to be about a year to 1.5 years away, which is quite a long time. And the reason being is that you need to make sure that it's not actually going to cause this virus to get worse. because there's a type of coronavirus that infects cats, and they tried to make an antibody or make a vaccination for that, and it actually made the disease much worse. Because what can happen is you can actually create antibodies that don't hold on to the virus in its whole circumference, and the virus will actually be, now instead of being enveloped, it'll be brought closer to the white blood cells and the cells that kill the virus, and just make it a lot easier for the virus to infect you. And so we need to be careful that that's not happening. Can you get it twice? At this time, it's not looking likely at all. But every virus can mutate, and this one is mutating, but only slightly, and it's remaining relatively stable. So they're tracking it at the moment. The reason why you have to get a flu shot every year is that the influenza virus is much poorer at replicating itself, whereas this one seems to be a little bit better. So no, you can't get it twice. There's been reports of some Japanese woman like getting reinfected or something, but I think it was more likely, and it's really unclear, like there's no medical literature on it. It's only like news literature, which is hard to decipher. But what likely happened is they had probably a pretty severe form of pneumonia or something of that nature, and they just developed complications at a later date. And so they probably needed to be re-hospitalized. So no, you can't get it twice. All right, I've talked a while. In summary, this is not the flu. It's 10 times more deadly and 2 times as contagious. So it's something to really, really take seriously. And flattening the curve is our best defense. The opportunity, as I mentioned, the DOTS of the R naught, decreasing this virus's opportunity to transmit from person to person is our best defense at the moment. There are treatments on the horizon, and remember, he va'a, he moku, he va'a, and that we're all in this, and our grace, humility, and love and aloha are going to get us through this. And I'd just like to dedicate a quick moment to all the healthcare workers on the front lines everywhere, but in New York City, that's getting hit really hard. Coworker of mine, James Solway, was also a consultant on that show. Lina Miyakawa is from Honolulu. Sam Kim, also from Honolulu, and Mark Maeda from Maui. So my hearts go out to them. They're right in the thick of things, and things are getting hairy for them at the moment. All right, I think that was enough. Questions? How do I get this?
Hey, that was so awesome. Sorry, that took a second. Everyone, you can type in your questions on the chat. You have to unmute yourself. So click to the bottom of your screen, and then you can unmute yourself and ask any questions you have. One thing that I was thinking about, I had some other questions, but you answered them all. That was so thorough. That was awesome. One thing I was thinking about was just like, what's your perspective on the timeline of all of this? Like, you know, it seems like we're a couple days behind from the mainland. Mm-hmm. Yeah, where do you, with everything that's at place now that we're shelter in place on Oahu?
Sure.
Predictions.
I agree with what Josh Green has been saying, is that we're probably going to reach a peak somewhere a month from now. I've been seeing cases almost, 1 or 2 per day, give or take, but not sick enough to be admitted. And so they've just been sheltering at home. And so it is out there in the community, and there is, without a doubt, community spread. And so it's great that we've had, the quarantine enacted by Ige. I wish he did it a little bit sooner. But I think with regards to sheltering in place, I think you could probably expect this all the way through May, give or take.
Wow. Yeah, it's pretty hard. I feel like it's finally settling in, even with like friends and stuff, that this isn't just such a temporary little snow day, It's pretty wild. We have a question that came in the chat. Are there any promising answers for creating more test kits?
Yes, actually, there was an Irish study done, our Irish team out of University College Dublin, who has it's uses some of the same technology as a pregnancy test. And you just drop a little piece of blood on this little thing that looks like a pregnancy test, and you get results within 15 minutes. And I don't know how accurate or reliable it is, but with 15 minutes test would be a game changer. And there's also now been some home test kits that have been developed. Whether they can get out manufactured quickly enough and in enough time, I don't know. I don't know the answer to that, but there are some developments going on with that. And I agree, testing is the only way to really get a handle on this, but testing was most important which Hawaii may still be in, is the containment phase, where, you know, you've got one person that's positive, and then you need to go and contact trace everybody who not only they came in contact with when they had symptoms, but 3 days before they had symptoms, because remember that latent and incubation period difference. So if the more testing that we have, the better. It's just, you know, everybody's clamoring after the same supplies. So
that's so awesome that there's some hope for something easier. There's another on what can the community do besides staying home to support the frontline medical workers, and along with that, maybe you know, just support each other through this time. I would love to hear your opinion on that.
Yeah, staying home is definitely the best thing. You know, no house parties, no play dates. As hard as that is, you know, I have the luxury of being able to go to work at least, and at least socialize somewhat and talk to people. So I feel for all of you guys who are at home. I know it's hard, but that definitely is the best way. Another way to help us is check in with anybody you know who works in the hospital. Give them love, give them shout outs, text them, let them know you're thinking about them. And it really, really helps to know that you guys are behind us and that you're thinking about us, because I'm quite admittedly, you know, my risk of perishing from this is low, 1 in 500. I'm 35 and healthy, but I've got coworkers who are who have diabetes, who have comorbidities, but are still showing up to work every day with not adequate PPE. So I guess another thing you can do is advocate for adequate personal protective equipment, or PPE, for us. You know, that would help.
I know that we're low on masks. What do you think about people helping with making those? Is that helpful? That's come up in some of our last meetings and thoughts. Is that?
Yeah, that is cotton mask, which I think most people are talking about making, right? Not like, you know, it's really hard to find a filter or get a medical filter in there, but cotton masks will definitely help give to the people who are sick. There have been pretty robust studies that have shown cotton masks for healthcare workers actually increases your risk of getting an airborne disease like influenza virus. I've seen people, and there's two ways you can take this. I've seen people out at the grocery stores or just out wearing bandanas or, you know, homemade sewn masks. And they're good in the sense that if you have a mask on, you're less likely to touch your face. I've probably touched my face, I don't know how many times during this lecture unconsciously, but more than once. It just happens, right? When you're out, it's our human nature. So if you can really focus on that and then wash your hands before you touch your face, I'm okay with a cotton swab or a bandana. But in general, if somebody's sick around you, a cotton mask is actually going to absorb those droplets and cause you to contract the virus sooner. But if you're going to make cotton masks, I would keep those probably in the community.
Awesome. Another question, so are the patients you send home likely to have COVID, and what do you think the ratio confirmed to unconfirmed cases currently are in Hawaii? Also, oh yeah, let's start with that.
Oh yeah, I can see the question there by Pono. Thank you, Pono. Good question. I think an estimate of how many people have this in Hawaii is probably closer to a couple hundred, maybe even 1,000 is a rough guess. Just, you know, people may have mild illness and not gone to the obtained care. to the amount of people that not just I've seen, but my providers that have seen that weren't sick enough to look like they had the flu, but they tested flu negative. I think it's probably closer to the hundreds than anything. And the second part of your questions, does it make any sense to buy gloves and masks and donate them if you see in the store? Depends what type of mask. If you see N95s, absolutely, or surgical masks, absolutely. Gloves we're actually doing okay with at the moment, but if you see some, that wouldn't hurt either. And then I see a third question here, swim goggles. Do we use them or not? I think it would probably be pointless if no mask. But really where you need the eye protection is when you're in like really up close face to face with somebody. Because again, swim goggles are usually inside the eye. And so you're gonna be touching around your eye a lot more when you either put them on or put them off. But we only use the eye protection when like I'm putting somebody on a breathing machine and, you know, I'm suctioning out their mouth and my face has to get really close to theirs, right next to theirs. So I would say no, swim goggles are probably pointless to be wearing out.
Cool. Does anyone else have any questions, or Don or Kino? I'm not sure if you do. Oh, there's one. Any other hopeful news on the virus, or just hope maybe in general? Like, do we I can leave everyone with that's a little hopeful?
Yeah. Any other hopeful news? I don't know specifically to the virus. One set of hopeful news was that the cases seem to be declining in New York. Whether that's they've had a decreased amount of testing or not, I don't know. But there was a temporary decline in the last day in the amount of new cases, which can be a hopeful sign. I think that's all I can say specifically to the virus, hopefully. Again, I'd remind people that 81% of cases, if you're young and healthy, most, you know, there are young and healthy people who are perishing from this, but you know, your risk is really low. So the most people have a really, really low risk. It's more of, you know, we got to help our kupuna from contracting this all at once because we want to protract this as long as possible. So we have the chance to save our kupuna, and we don't have to ration our amount of ventilators and all those things. Okay, if you did get corona, how long till you're safe to interact with others? Generally, they say if you've had 3 days worth of no fever and no cough. Mostly it's you've had 3 days of no fever and you haven't had to take like Tylenol for it. So 3 days after you have symptoms. But I would just err on the even more cautious side. I would say at least 5 days and still wear a mask. Symptoms usually last, if they're mild, for about 10 days, give or take, which is a lot longer than the flu. Flu is usually about 5 to 7 days. So if you just have mild symptoms, it's roughly about 10. Yeah, I know. I wish I had more hopeful news for you guys, but you know, there is hope. There are treatments on the horizon, and we're humans. We're ingenious, and you know, we can get through this as a community, as together.
Yeah, I love kind of ending on that of just yeah, the unity that's kind of coming from all of this. And we're trying to, at Treehouse and with our members and broader community, to support each other and move forward and be supports for each other's struggles with business, but also personal stuff as well, and hold these events. And we're starting to do more virtual events, just fitness challenges and stuff like that as well. So I love that. Oh, it looks like Don had a question come through too.
Coming back to Fomite, say you brush up, okay, if you brush up on something at the store, on a jacket, is it necessary to be worried about this contact? I guess it depends on where you brush up against it. Is it your hand that touched it and you didn't wash your hand? If your elbow touched it, there's a small but chance, it depends if somebody touched that jacket in itself. There's a small chance there could be virus on that. You know, I don't want to make anybody paranoid, but you know, it's better to be safer than not. There is a small chance that that could have had some virus on it. Yep. Work out, meditate, stay inside, support the elderly. Perfect.
Yay. Awesome. Cool. Yeah. And if anyone has any other questions, we can revisit this. And we've talked to Dr. O'Carroll about doing a follow-up talk. Next week, you said your schedule's kind of crazy, which is understandable, but next week or the week after, it'd be awesome to just get an update on where we're at in Hawaii and if there's any new information on what we can do to stay healthy and or support the community. Yeah, any last things you have for us?
No, I think I've talked enough. I don't want to be any more bummer.
Yeah, that was so informational.
Yeah, that was great. And everyone else will be sending out the link to this, and so you can have the presentation and stuff as well. Yeah, we appreciate your time so much. That was super informational.
Yeah, hopefully it wasn't too detailed, but you know, more knowledge is power. So
yes, totally.
Yep.
All right.
Thanks, Darragh.
For being here.
Hey guys.
Chihu.
Yeah.